this lecture on trauma, trauma shock detection, assessment, and management. And this lecture is based on the latest recommendation of American College of Surgeons in its advanced trauma life support programs. Just look at this case scenario. A 28-year-old female involved in a high-speed motor vehicle collision brought to emergency department with a pulse rate of 126 per minute, blood pressure 96/70, respiratory rate of 28. She is confused and anxious. Is this patient in shock? If so, what kind of shock is this? And how do you manage this shock? Objectives of this lecture include to define shock, to recognize the shock state, to determine the causes of the shock, and to discuss the treatment principle, to recognize the importance of early identification and hemorrhage control of a shock hemorrhage. By definition, shock is an abnormality of circulatory system that result in inadequate organ perfusion and tissue oxygenation. And basically, shock is an imbalance between the oxygen delivery and oxygen consumption at tissue level. As it is a cellular event, an inadequate cellular oxygen delivery will lead to anaerobic metabolism. This anaerobic metabolism in turn leads to inadequate energy production, and this inadequate energy production in turn leads to metabolic failure. The anaerobic metabolism will also lead to lactic acid production and metabolic acidosis. The metabolic failure, when coupled with the metabolic acidosis, will lead to the cell death.
Shock or hypoperfusion is the inability of the circulatory system to supply cells with oxygen. In early stages, symptoms occur as the body attempts to compensate for blood loss. Physiological causes of shock are the heart failing to pump, loss of blood volume, or blood vessels dilating, creating a vascular container capacity that is too great to be filled by available blood. Categories of severity are compensated shock, presents as an increased heart rate, increased respiration, and constriction of peripheral circulation, which results in pale, cool skin and in infants and children, increased capillary refill time. Decompensated shock starts with low blood volume or lack of perfusion. Symptoms include falling blood pressure. Shock is irreversible when perfusion to the organs cannot be restored. Cell damage occurs, especially in the liver and kidneys. Even if vital signs are restored, irreparably damaged organs may cause death. The main types of shock are hypovolemic shock, caused by uncontrolled hemorrhage, internal, external, or both, or by plasma loss in burns or crush injuries. Cardiogenic shock occurs during a myocardial infarction or heart attack. Damaged heart muscle or electrical malfunctioning decrease the strength of the heart's contractions, causing a slow, fast, or irregular heartbeat. Neurogenic shock may result from the uncontrolled dilation of blood vessels due to nerve paralysis in spinal cord injuries. There is no blood loss, but the blood vessel dilation increases the capacity of the circulatory system, and available blood can no longer fill it. Sepsis, massive infection, or an anaphylactic or severe allergic reaction may also cause shock from blood vessel dilation. As an EMTB, you do not need to diagnose the type of shock. Instead, you must recognize and treat for shock whenever there is a mechanism of injury or signs that indicate the possibility of shock.
So, how do I recognize a shock? To recognize shock, apart from its clinical presentation, you should also need some information from the scene, like what is the mechanism of injury, what was the accident, etc. And this should be coupled with an ample history. Ample history is a focused history which includes the history of allergy or anaphylaxis, M for medication, P for past medical or surgical history and pregnancy, L for last meal or LMP, and E for the event. How will you clinically recognize as a patient is in shock? For that, you look at what is the level of consciousness. What is the level of consciousness and anxiety level? Look at the periphery. How is the cold? Whether the skin is diaphoretic, is a tachycardia, and also tachypneic, shallow respiration, hypotension, and urine output, decreased urine output. All the signs of while managing, assessing and managing the shock, the focus is not different. It is always airway, breathing, circulation, disability, and exposure and environment. So, while managing a shock, always follow the concepts of trauma initial assessment and management chart, where it's always start with a primary survey which comprises A, B, C, D, E, airway, breathing, circulation, disability, and exposure. While doing the primary survey, to support the primary survey, you can also use the adjuncts of the primary survey like X-ray chest, SpO2, X-ray pelvis, IV access, then basic blood lab, etc. Parallelly, while doing the primary survey, whenever you are detecting a problem at any stage of airway, breathing, circulation, or disability, you should resuscitate it. And the management is comprises the coupling of assessment and management and evaluation, re-evaluation. Every phase you should go assess, resuscitate, and re-evaluate. And once the patient stabilizes at A, B, C, D, E level at the primary survey, then you can go for a detailed secondary survey along with its adjuncts. And again, you re-evaluate for the results. And if the patient is stable, it can be shifted for a definitive care or a destination care. So how do you locate the bleeding site? For that, you can use the primary and secondary survey, that is the physical examination, and also the diagnostic adjuncts like X-ray chest, X-ray pelvis, FAST and DPL. FAST means focused assessment sonography in trauma, and DPL is the deep peritoneal lavage. How to decide the cause of bleeding? The response of the initial treatment couples with the finding during the primary and secondary patient surveys usually provide sufficient information to determine the cause of shock state. There are two critical steps in the management. The step one is recognize the presence of shock. The initial diagnosis is based on the clinical appreciation of the presence of inadequate tissue perfusion and oxygenation. Practically, no laboratory test will help you to diagnose the shock in the initial state, where the only way to diagnose is the presentation, clinical presentation. The step two, once you identify the presence, let's identify what are the cause for this shock state. Broadly, there are two, like the hypovolemic and two type of shock. There's the hypovolemic and non-hemorrhagic shock. A hypovolemic shock or a hemorrhagic shock basically due to a fluid loss or a blood loss. Non-hemorrhagic shocks are due to tension pneumothorax, cardiac tamponade, cardiogenic shock, septic shock, and neurogenic shock. In vast majority of trauma patients, shock is due to the blood loss, unless otherwise proved. In a isolated head injury cases, isolated brain injury cases never cause a shock per se. There should be always a secondary bleeding sites. Then, how the body will respond to the blood loss? Definitely, it is an early circulatory response to the blood loss or compensatory. Usually a progressive vasoconstriction of cutaneous, muscular, and visceral circulation. This is basically to preserve the blood flow to the kidney, heart, and brain, or to preserve the blood flow to the vital organs. What are the earliest signs of shock? Tachycardia is the earliest measurable circulatory sign of shock, and along with that, an increase in the diastolic pressure and a decrease in the pulse pressure is also will be there in early shock. In an insured patient who is cool and tachycardic is in the shock until otherwise proved. So whenever you are using tachycardia as a measurable tool for assessing that shock, you should also know what is the normal tachycardic range for different age group. For an adult and a heart rate of more than 100, you can consider as tachycardia. For an school children, it's more than 120. A preschool children is more than 140, and an infant it is more than 160. And also you should be take this group like extremes of age, athletes, pregnancy, beta blockers, cardiac patients on cardiac pacemakers, patients on cardiac transplants are should be considered a special group because they will present very differently when you are using their tachycardia as a measure for the shock, because they may not be present with the tachycardic at all. In the treatment goal including 3 level, one is the restoration of the volume is already low and control the hemorrhage, and again assess the response to the initial therapy. The presence of shock is a surgical condition. It demands an immediate involvement of surgeon. What about the uses of vasopressors to bring up the BP? Vasopressors are contraindicated for the treatment of hemorrhagic shock because they worsen the tissue perfusion. Whenever managing the hemorrhagic shock, the volume replacement is the mainstay of treatment, and the vasopressors has no role at all. How you assess the fluid and blood loss based on the patient initial presentation in a case of trauma. The hemorrhage can be classified into 4 classes, class 1 to 4, depending upon the loss of blood and their clinical presentation. A class 1 hemorrhage where the blood loss is about 750 ml, that is 50% of the blood volume, usually present with slightly in an anxious state with normal blood pressure, normal heart rate, normal respiration, and normal urine output, where the treatment modality is mainly crystalloid. In a class 2 hemorrhage, where the blood loss is approximately 750 to 1500 ml, that is 15 to 30% of the blood volume, they will be present in an anxious state where the normal blood pressure, but they will be tachycardic, heart rate is just above normal, more than 100 per minute, with decreased blood pressure, decreased pulse pressure, almost normal respiration, and normal urine output, where the treatment is crystalloid. Sometimes your patient may require blood. In class 3 hemorrhage, where the blood loss is much more, where it's a 1500 to 2000 ml, or that is 30 to 40% of the blood volume, they will be present in a confused state or an anxious state where the blood pressure will begin to decrease, heart rate is begin to increase above 120 per minute with a decreased pulse pressure, with higher end respiration and lower end urine output, where the treatment modalities include crystalloids, blood and blood components, and may require surgical interventions also for controlling the bleeding. In the class 4 hemorrhage, a severe form of the hemorrhage where the blood loss is more than 2000 ml, with that is more than 40% of the blood volume already loose, and they will be confused and lethargic, presented with a severe hypotension, with the heart rate is more than 140 per minute, with a decreased pulse pressure, in respiratory failure, and urine output is also decreased, as in acute renal failure, where the treatment is the blood and blood component along with the definite hemorrhage control, that is a surgical hemorrhage control. In summary, the class 1 hemorrhage is present with a blood loss of 750, less than 750 ml of blood loss, that's a 15%, present with a normal heart rate, normal blood pressure, normal pulse pressure, normal respiration, urine output, maybe slightly anxious, and their treatment modality is mainly crystalloid. A class 2 hemorrhage is present with blood loss of 750 to 1500 ml of 15 to 30% of the blood volume, present with tachycardia and decreased pulse pressure, but and they'll be mildly anxious, but their respiratory rate and urine output is almost normal, and their treatment is again with the crystalloid. A class 3 hemorrhage where the blood loss is 1500 to 2000 ml, that is 30 to 40% of the blood volume. They will be present with a high heart rate that is more than 120 per minute, with a decreased blood pressure and decreased pulse pressure, high respiratory rate and low urine output, will be confused and anxious, and treatment is crystalloid and blood. A class 4 hemorrhage is severe, worst form of the hemorrhage where the blood loss is more than 40% of the blood volume, that is more than 2000 ml, with the heart rate of more than 140 per minute, with a decreased heart rate and pulse pressure, and respiratory rate is more than 35, that is in respiratory failure and urine and kidney failure. They will be lethargic and confused. They require early surgical intervention and fluid and crystalloid blood therapy. So always, whenever you are administering the fluid and blood, you should also respond the initial volume therapy. The patient, how do you assess the response of the fluid therapy? For that, you just look at the improvement of the organ perfusion, like look at the skin, whether it's back to warm and normal, back to the normal capillary fill. Look at the renal function, how the urine output is improved. Look at the vitals, how this is back to normal, and look at the CNS, how these improve the level of consciousness. And whenever your urine output used as an index of the cardiac output, you should also know, particularly when you are treating in a pediatric cases, you should also know that what is the normal urine output for different ages, because for an infant or an children less than 2 years, the normal urine output is 1 to 1.5 ml per kg, and for a preschool children it is less than 1 ml per kg, and for a children of a child of 6 to 12 years, the urine output is 0.5 to 1 ml per. And this patient, you should know how to decide and differentiate the response of the fluid therapy, because this is the main key is the main key to determining the subsequent therapy. And should also distinguish a hemodynamically stable patient from a hemodynamically normal patient. What we want, a hemodynamically stable patient rather than a hemodynamically normal patient. So your patient will respond to the fluid therapy differently. Depending upon the initial response to the fluid therapy, your patients can be divided into three categories. They are like early responders or the rapid responders, transient responders, and no responders. An early fluid therapy means the early bolus of crystalloid of 200 ml or a 20 ml per kg for a children. So the patients can be categorized into rapid responders, transient responders, and no responders depending upon the features. And the rapid responders mean they return back to normal with in early fluid therapy. That means these patients, their blood volume loss is less than 20%, and they less likely or less need of crystalloid or blood therapy. And if at all a blood is needed, you can give a type specific cross-matched blood. You will get time for that. And there may not be need the they may not be need they may not be may need a surgical consultation, but may not be need a surgical intervention. Transient responders, they respond to your fluid therapy appropriately in the initial phase, but immediately after some time they will going back to the original state. They again their BP will begin to decrease, their heart rate begin to increase. That means their blood loss is moderate, that is 20 to 40%, and they required the more fluid, high volume of fluid is required more blood, moderate to high blood therapy is required. But you can give a type specific blood. You may not be wait for to get a cross match. They likely to require surgical intervention and surgical opinion. And non-responders are really a troublesome group. They are not responding to your initial volume therapy. They remain abnormal. That means their blood loss is more than 40%. They may also having the other issues like tension pneumothorax, cardiac tamponade, or retroperitoneal bleed, myocardial injury, etc. These patients require a high volume of the crystalloid and require immediate blood transfusion. You may not wait to get a type specific or a cross match blood where you can use a O negative blood, and they highly required immediate surgical intervention and surgeons involvement. And management strategy again focuses on again A B C D E, and to establish IV oxygen and monitor. This is the mantra of trauma management: A B C D E, IV oxygen and monitor. And when managing the shock, always put two large bore cannulae in the peripheral vein, not in the central vein, it is in the peripheral vein, because this will infuse more volume and more fast. And infuse large volume of crystalloid, warm crystalloid rather than ordinary crystalloid. And also decompress both the bowel and bladder. While decompressing bowel and bladder, try to rule out the urethral injury, do the PR and proper perineal examination. And don't forget to monitor the response to your early therapy and to prevent hypoxia. And surgical intervention, the intervention to stop bleeding include several, like give the direct pressure or tourniquet if there is no VS external bleed, reduce the pelvic volume in a case of fracture pelvis by using a pelvic binder, go do the early surgical intervention and operative control of the bleeding, and splitting of the fractures also bring down the blood loss. And if an uncontrolled hemorrhage, think about the possibility of angioembolization. And somebody is not responding to your early crystalloid and blood administration therapy, always think about the myocardial injury, cardiac tamponade, tension pneumothorax, neurogenic shock, and ongoing hemorrhage in the peritoneal, retroperitoneal area, or an internal organ injury. What fluid you want to use? Your fluid of choice is always stringer lactate in the initial fluid therapy, and only normal saline will come as a second choice. Blood and blood component should be used as required. What are the pitfalls in management of trauma shock? These include different, like the patient factors like age, extremes of age, ATLS, pregnancy, medications, and pacemakers. This group are considered special group because they will not be present with the normal way of the tachycardic and other response of the blood loss. So whenever managing this case, you should be cautious about the variations of the normal or the response of the normal response of the volume loss. Whenever managing the shock with a high volume of the fluid, you should be focused on the prevention hypothermia, because the hypothermia may likely to cause coagulopathy and failure to resuscitation. And when you are using the blood pressure to as an index of the shock, it will be a big disaster, because you cannot equate BP with the cardiac output. It's always misleading. And hemoglobin level and hematocrit level of the blood loss, index of the blood loss, is also misleading. So don't use BP, hemoglobin and hematocrit as an index of the shock management. And regarding the pediatric trauma shock, The pediatric cases are present normally in their index like heart rate, blood pressure, and cardiac output till up to more than 40% of the blood loss or the volume loss. So, if you are not resuscitating a pediatric case aggressively in the early phase, some point the patient will crash in front of you and you will lose the patient. And in summary, shock the is a is the inadequate organ perfusion and tissue oxygenation, a state of inadequate organ perfusion and tissue oxygenation. Hypovolemia is the cause of the shock in most of the trauma patient, and the patient may present with a mild to severe shock. The conduct of a rapid initial assessment and resuscitation is important. Determine the cause of shock always, stop the bleeding whenever possible, and re-evaluate always and always. Re-evaluate always and always. The mantra is assess, manage, and re-evaluate. Assess, manage, and re-evaluate. And thank you for